Dr. Syed Gilani from UTMB Galveston. Syed.
Thank you, Dr. Reisner. It's a pleasure to be here to speak with the fellows. I was given the task to cover in 10 minutes. So my objectives are to go over the diagnosis, treatment options, reperfusion options, and post-reperfusion management briefly. And most of this will be coming from my clinical experience, some of the examples, and directly from the guidelines, which are 2013 guidelines. So to start off with, I don't want you to interpret the EKG, but do try to focus on what you think might be the diagnosis. To the left, this is a patient who's presenting with 1 or 2 days history of chest pain and abdominal pain. She was admitted to medicine service, transplant service, and cardiology was consulted because the initial set of cardiac enzymes was abnormal. Her presenting EKG is to your right, to your left, and shows pretty much normal, right? So the patient was initially treated with ACS, possibly ACS, and started on anticoagulation, aspirin, and repeat EKGs and repeat enzymes. As you can see, over the next 24 hours, patient developed some pancytopenia, decreasing white counts, and the EKG dramatically changed. So what do you think, STEMI or not STEMI? There is diffuse ST elevations, right? And there's some PR depression and there's some PR elevation in the AVR. So again, this is not a truly set diagnosis of acute MI, but it's suggestive of ST segment elevations. This patient underwent a transthoracic echocardiogram that showed moderate pericardial effusion, and over the course of hospitalization, she was diagnosed with ITP and pericarditis associated with that. This was another patient who presented to the emergency room with nausea, vomiting. He has risk factors for heart disease, and you can see his EKG. You don't have much time. This may be the EKG that's handed to you, and you're going to be the one making the diagnosis, and you may be sweating. Okay, you want to make the right diagnosis. You don't want your co-fellows and your faculty to be upset at you for wrongly activating the cath lab. So STEMI or not STEMI? There's ST segment elevations in the anterior wall, and you don't have time to wait for the enzymes. I guess you can if you want to, but you may lose your 90-minute target. So while cath lab was activated in this case, because there is ST segment elevation, the patient does have nausea, vomiting, and has risk factors for heart disease. While the labs were coming, patient was already in the cath lab table, and the cath lab was done. Cath angiogram was done, showed normal coronaries. In the meantime, a fellow shouted at me, "By the way, Dr. Gilani's potassium is 8.5." So think about that diagnosis. Okay. This is a patient who came to the hospital with 3 days of chest pain, off and on, and at the time of presentation, he was continuing to have chest discomfort. And you can see his initial EKG is completely normal. There's no sinus rhythm, not even tachycardia. Everything looked great. One thing that was missed was the left lateral EKGs was not done. So if you have a patient with chest pain suggestive of possible ischemia and the EKG is normal, consider doing left lateral leads because you may be missing a posterior lateral MI or basal inferior MI that's now called. So this patient was, over the course of hospitalization, continued to have trending enzymes and was taken to the cath lab eventually, and you can see his proximal to mid-circumflex is 100% blocked, and he was underwent revascularization. So on standard 12-lead EKG, circumflex territory could be silent. It has been well reported. And this is another example of a 37-year-old male who came to the hospital with typical symptoms of angina. Risk factors, do you think STEMI or not STEMI? STEMI, inferior wall ST elevations, right? And clinical syndrome sort of fits. Underwent an angiogram that showed RCA mid-occlusion, underwent revascularization, and did well. This is another patient who came to the hospital with 64-year-old with chest pain, shortness of breath, and diaphoresis 30 minutes ago. He underwent RCA angioplasty 10 years ago, was off aspirin for 5 days because of colonoscopy. So STEMI or not STEMI? Inferior ST elevations, having chest pain, prior coronary artery disease, you're bound to do an angiogram. So this patient had instant thrombosis or so-called maybe new atherosclerosis-related plaque rupture. Underwent an angiogram. This patient, contrary to the previous patient, was very, very symptomatic. Was bradycardic, hypotensive, which if you had done a right-sided chest leads, V4R or V3R, you might have been able to pick up the RV infarction. This patient was very symptomatic and underwent revascularization, and at the end of the revascularization, once you open up the artery, the patient was pretty much back to baseline. A pacemaker was taken out, did not need hemodynamic support. So this is another example of a 53-year-old male with shortness, with left shoulder pain. That's an hour recurred, so he came to the emergency room. So you can see the old EKG and the EKG at presentation. STEMI or not STEMI? So there is 2 millimeters or more ST elevations in V2 and V3, and there is 1 millimeter or more ST elevation in V1 and V4. So you have anteroseptal infarction. Okay, you have to call it that, at least on the EKG. Okay. So this patient, STEMI was activated. It was taken to the cath lab, and he had proximal LED, ostial LED occlusion. Underwent revascularization, and did well. This is post-PCI. You can see the EKG, sometimes the EKG changes take time to resolve. Still had residual Q waves and SC segment elevations better than baseline, but it was chest pain-free, symptoms without symptoms. 62-year-old female, obese, hypertension, presented to the ED with severe chest pain, shortness of breath. And this is another patient who, now this time, this patient is very symptomatic. While she was being transferred to the cath lab, she actually needed to be intubated because of acute onset of respiratory failure, most likely pulmonary edema. So you can see her EKG, no doubt, right? So this EKG compared to the previous EKG, this is definitely STEMI. The anterolateral ST elevations, anybody can pick it up. Okay. So this patient had a proximal LED occlusion, underwent revascularization, and she required balloon pump and eventually was discharged from the hospital very well. Post-PCI, you can see this residual ST segment elevation was dramatically better compared to the pre-PCI. This 47-year-old male with chest pain, nausea, sweating, comes to the emergency room, and this is his old EKG for comparison. You can see the EKG on arrival. And again, this EKG is not that dramatic for the anterior ST elevations, but per guidelines, 2 millimeters or more ST elevation at J point, horizontal or upsloping in a V2 and V3 will qualify you for anterior MI. So this patient, the computer doesn't read it that way also. And so this patient, STEMI was activated because sometimes very early in STEMI, you can only have hyperacute T waves, and you can see there's hyperacute T waves in the anterior leads. Now that you have a luxury to have an old EKG for comparison, sometimes you may not have that. So this patient was taken to the cath lab, had a proximal LED occlusion, acute occlusion, underwent revascularization, and did well. And this is post EKG. You can see there's some residual changes that are starting to improve, and he's trying to gain his R wave in the anterior leads. This is another 57-year-old male with chest pain since yesterday, constant 5 out of 10, came to the emergency room, and no prior history of CAD. So old EKG for your comparison, and you can see his EKG. So what do you think? High lateral STEMI, very good. So you can see there's some barely 1 millimeter inferior ST elevations, and there's definitely 1 millimeter ST elevation in V5 and V6. So that tells you there's a lateral wall involvement in this patient, and he's having symptoms. So that correlated very well with the obtuse marginal occlusion. Patient had a large obtuse marginal for a branch of circumflex, and underwent revascularization for that, and did well. This is the thrombus. This is a 73-year-old female nursing home resident. The only history you have from the EMS is patient was shortness of breath. They were called in. Patient was intubated in the field and brought to you. This is the EKG. Patient is intubated. No family available. You're going to have to call it one way or the other. What do you think? STEMI, not STEMI? STEMI, right. There's anterior ST elevation. There's no doubt you have to sort of consider the ST segment elevation, right? And then the history may be. So this underwent an angiogram. Angiogram showed normal coronaries, and this patient had a stress myopathy called Takotsubo's cardiomyopathy. You can see trending enzyme did not show any significant elevation, but in the early on, you don't have a luxury of having all of these in your pocket. So a week later, her EF recovered back to normal, and this is her EKG afterwards. You can see dramatically improved just by medical management. This EKG STEMI was activated from an emergency room. Patient who all the history you can get is the patient was not feeling good. EMS arrived. Patient collapsed while taking blood pressure, intubated, and there might have been some tachyarrhythmia, but no defibrillation required. So you have an old EKG for comparison. At the time, patient presented for atypical chest pain and arrival to ED. You can see there is SC segment elevation in 1 and AVL. Okay, and the computer is also calling it, so you have to overread it if you don't want to call it. So what do you think? Okay, so there is SC segment elevation, but the history, patient collapsed. Patients don't usually collapse without a VFib, and they usually require defibrillation out of it. They don't wake out of VFib usually. So what do you think? You would give this patient anticoagulation, send him to cath lab? Okay, good. So this is the EKG. I just zoomed it up for you guys. This patient appropriately was taken to the CT scanner before bringing to the cath lab. So she was eventually going to come to the cath lab. The CT scan of the brain was okay, and the CT scan of the brain showed intracranial hemorrhage. So consider that in your differential diagnosis if you're not clear, and it's always okay to do that, I'm telling you. This is another 46-year-old male with unknown history brought to the ER. Patient visiting for Austin for vacation in Galveston was running. Bystander thought that the patient stopped and leaned against the pole and then had a seizure. So EMS was called, and patient was was brought to the ER, very sedated by the EMS and unable to provide history. So STEMI or not STEMI? These are anterior ST elevations. And patient had a seizure. Okay. So like I said, always appropriate to call it a STEMI, but send it to the CT scanner first before you bring it over, before give the patient anticoagulation. This was just a few weeks ago, by the way. The patient had intracranial hemorrhage. So if you have ST elevations, consider that if you don't have a typical history, or you're not sure of the patient's brain status. 59-year-old male, okay, was with history, multiple problems, had chest pain earlier, repeat chest pain came back, so he called 911. EMS came, and appropriately so, they did an EKG that showed no significant ST elevations. The bottom EKG is the first EKG. Then there was astute EMS person. He kept on repeating the EKG. So he repeated another EKG, nothing, no change. Then he repeated another EKG in the field that showed ST elevations. So again, this could be a dynamic process. So if you don't have a negative, do have a negative EKG, always per guidelines repeat EKGs consistently every 5 to 10 minutes until you're sure this is not an ST elevation. This patient was inferior all ST elevation. On arrival to the emergency room, the EKG has also turned back to normal. Okay. So taken to the cath lab, had RCA tight, possibly a plaque rupture in the mid RCA, underwent PCI of that, and those changes did not come back. So again, how do you diagnose STEMI? It's a clinical syndrome of symptoms associated with persistent ST segment elevation, and eventually you will be cardiac biomarkers will be elevated. I gave you the examples of differential diagnosis with consider hyperkalemia, consider Osborne waves, consider an acute pericarditis, Brugada syndrome, normal variant, or ischemia, obviously, ST segment elevation MI. In the past, per guidelines, there was a lot of stress on giving IV beta blockers to these patients in the ER, but no longer, because you have to make sure you don't give patients, you can give oral beta blockers to these patients, but particularly not for these patients who have signs of heart failure, evidence of low state, or increased risk of cardiogenic shock, and the risk factors for that is listed to the right. So there's not a lot of stress now. You have to put the patients on beta blockers within 24 hours, but don't have to you're not forced to give them in the ER. You have two reperfusion strategies. Primary PCI, which is always preferred, if it can be performed within 90 minutes of first medical contact, that is we have to remember. And if that cannot be performed within 90 minutes of first medical contact, then possibly fibrinolytic therapy if the patient is the candidate. So reperfusion therapy, time goals are if the patient has ischemic symptom within 12 hours, onset a class 1 recommendation for primary PCI. If the patient has contraindication for fibrinolytic therapy, then you have to transfer the patient regardless and get the primary PCI done. And goal should be to minimize the time and definitely keep it within 120 minutes of first medical contact. You can do primary PCI for patients who have symptoms of 12 to 24 hours of onset. And if the patient is asymptomatic, then obviously, or shock, there's no time limit for that. You have to revascularize these patients. PCI of the non-infarctated related artery is still, per guidelines, is considered as harm, but there's growing evidence of back and forth. You can do it or you may not do it during the same hospitalization. Then for fibrinolytic therapy, if the patient is first arrives to a hospital that cannot do primary PCI, then you have an option to transfer or give them thrombolytics. Okay, if you transfer the patient, if you cannot get the PCI performed within 120 minutes of first medical contact, then it's preferable to give these patients thrombolytic fibrinolytic therapy. It's class 1 recommendation. So if anything you have to take out of this talk, take this table. Okay. So this is the very simplified version now in the most recent guidelines of how you should manage patient with ST segment elevation MI. So if patient with STEMI comes to who's a candidate for perfusion, comes to a hospital that can perform PCI, goal is to get these patients to the cath lab as soon as possible to perfuse them with PCI. Within 90 minutes is the maximum goal, but the earlier the better. Okay. But if the patient ends up in a hospital that cannot do primary PCI, so now you have to either transfer the patient or give them thrombolytic. So if you can get this patient transferred, you're sure you can do that by a proven mechanism from that hospital to a primary PCI capable hospital and get this patient in the cath lab and get it reperfused within 120 minutes of first medical contact, then you should do that. Okay, transfer the patient, get the patient into for PCI. But if that goal cannot be achieved and you're not sure, it's always best to give this patient thrombolytic at the hospital within 90 minutes, within 30 minutes of arrival to that hospital. Okay. And then after you give in thrombolytics, then you have a class 2A. It's reasonable to transfer pretty much all these patients to PCI-capable hospital for revascularization within 3 to 24 hours of thrombolytic therapy. That's class 2A indication. And if you have a failed reperfusion, if you gave thrombolytic, you definitely have to urgently transfer these patients as soon as possible for PCI-capable hospital for angiogram and reperfusion. And that failed reperfusion means within 90 minutes of giving thrombolytic therapy, you still have less than 50% resolution of ST segment elevation. Or if it resolved, then it came right back, and then obviously you have a recurrent MI and you have to transfer these patients. How do you treat these patients urgently? So antiplatelet, anticoagulant therapy, aspirin, and among antiplatelet, you have to keep these patients at least 2 antiplatelet agents. Okay, aspirin is always one of the choices unless the patient is allergic to it. So aspirin, you should always load these patients with loading dose, which is 162 to 325 milligrams oral, and followed by preferably 81 milligrams daily for life. Among the second antiplatelet agents, you have 3 choices. You have ticagrelor, you have prasugrel, or you have clopidogrel. All have class 1 recommendation. Okay, and you can pick your choice. And there's some nitty-gritties about that, which patient might benefit with one over the other. But per guidelines, each one of these, pick one of these 3 is class 1. Okay. Then acute treatment during primary PCI, it is reasonable to start these patients on 2B3A inhibitor, and you have 3 choices: epsiximab, eptifibatide, and tirofiban. They have slight differences in the duration of action and how they work, the size of the molecule, but all 3 of them have class 2A recommendations for use around the time of the primary PCI. And then pre-cath lab administration of 2B3 inhibitor, you can consider them class 2B, preferably in patient. If the patient was getting transferred for PCI, you can, at the outside hospital, you can give this patient 2B3 inhibitor, because in trials it's been shown to increase the perfusion of the artery, increase the artery that is perfused by the time you do PCI. So it improves the outcomes, but only it's a class 2B recommendation. Okay. Intracoronary epsiximab can also be used. Class 2B indication, there's some studies that showed some composite outcomes, clinical outcomes, and surrogate endpoints have improved by using intracoronary epsiximab at the time of the PCI in STEMI patients, just a bolus, not the infusion. So what do you use? Those are the antiplatelet agents. You have to pick at least 2. Okay. So, and then you can use the third one, 2B3 inhibitor, on an elective basis, on a selective basis. Among the anticoagulants, you have to pick at least 1. So either it's unfractionated heparin, is class 1, bivalve, class 1. So bivalve may have preference over unfractionated heparin. It's reasonable to use that as class 2A indication among patients who are high risk of bleeding, and this came from Horizon AMI STEMI population trial. So if you had used fondaparinux, it's class 3 recommendation to use that at the time of the PCI. So if the fondaparinux is initially used as a medical therapy for patients with STEMI, you have to switch that to another anticoagulant, unfractionated heparin or bivalve at the time of the PCI, because fondaparinux is class 3, can cause harm based on the study that shows increased catheter-related thrombosis during percutaneous coronary intervention. So if you were to use fibrinolytic therapy, make sure you go over detailed absolute and relative contraindications before you administer it. These are listed. You have 3 choices in the US of the fibrinolytic agents. It's either TNK, it's RTPA, or TPA. The benefit of TNK and RTPA is a relatively simpler administration. So TNK is the 1 bolus therapy, period, you're done. The other one is two boluses, whereas the TPA, which is almost just as good as the other 2, it requires 90 minutes of total infusion time. It's first bolus followed by another bolus and then another bolus for 60 minutes, which is different doses. So total dose has to be less than or equal to 100 milligrams based on weight. So you give the TPA or one of these 3 agents, and any one of these could be picked based on the availability. What do you do with adjunctive therapy with fibrinolytics? Once you've given thrombolytic therapy, you have to give that patient aspirin and Plavix and 1 anticoagulant agent. Say again, 2 antiplatelet agents and 1 anticoagulant agent. You can pick an aspirin. Obviously, you're going to pick aspirin for all patients. If the patient is less than 75 years of age, you can give the patient 300 milligrams of bolus based on the COMMIT trial and continue 75 milligram daily after that. And if the patient is more than 75, it's preferable to give his class 1 to only give 75 and not the bolus because there's high risk of bleeding associated with the thrombolytic therapy and Plavix bolus early on, age 75 years or more. Then among the anticoagulants, you have the choice to use heparin, enoxaparin, or 400-paranox, any one of these three. And caution is for renal insufficiency in 400-paranox and enoxaparin, you have to adjust the dose. Okay. So if this patient after fibrinolytic therapy goes for PCI, the strongest evidence to use obviously Plavix and heparin for the PCI. And if the patient has already received bolus of Plavix, you just continue 75 milligrams a daily. If the patient did not receive bolus of Plavix, then you can give the loading dose of 300 if the PCA is performed within 24 hours. If it's more than 24 hours, you can use Plavix 600 milligram bolus. The only one of the newer antiplatelet agents, which is Prasugrel, in the Triton TIMI 38 trial, they included patients who had received fibrinolytic therapy more than 24 hours ago. So that's why there's a class 2A indication. You can use Efient more than 24 hours after the fibrinolytic therapy if you're doing PCI in these patients. So with that, I would like to stop. I'll be happy to answer any questions. Thank you.